scapula. So the first joint would be the sternoclavicular. So that's between my wonderfully drawn sternum right here and the clavicle. So the medial portion of the clavicle. So if we went closer into it, like just to cover the actions that it can do, is it can do elevation and depression of the scapula. It can also do anterior rotation and then posterior rotation. And then finally some protraction and some retraction. So those are all of the actions that it can do at once. So that's honestly a lot of things going on for just one movement of the humor, like one visual movement, but there's a lot going on around scenes. Next, we're going on to the acromioclavicular. So that's the distal end of the clavicle attaching to the acromion of the scapula. So that's right here. And that one has upwards and downwards rotation. So this has to do with now the scapula. So upwards rotation and then downwards rotation. And the whole time you want to be looking at the inferior angle. And that's how you know. So if this is tilted upwards, you can tell it's upwards rotation and so on. And then internal external rotation is the idea of how to explain it well in a 2D drawing. Like internal rotation and then external rotation is the idea of just the kind of like the side tilting. So say it's on an axis going through right here, and then it can tilt to either side of it. So it's that type of rotation. See, I just didn't want to get confused with anterior posterior tilting, which is also a movement. So we'd say that's on this axis right here. And that's right at the inferior angle. So posterior tilting would be it kind of pointing back. So if you felt the back, like your upper back right by the scapula right at the inferior angle, you'd be able to feel it protruding during posterior tilting. And then anterior tilting as it kind of goes in. That's the best I can do to explain it. And then there's also the scapulothoracic, which is kind of it's not real joint, and that's like this area. That's like the interaction with the scapula and like the rib cage and everything. And so the good thing about the scapulothoracic is it's kind of a combination of the sternoclavicular and acromioclavicular in that they do their motion, and the scapulothoracic, you can say, always mimics one of their motions. But you'd have to know if it's acromioclavicular or sternoclavicular. So some easy ways to do that is the idea that scapulothoracic always has to do with the scapular motion. So it wouldn't really make sense if, say, during abduction, we have elevation of the scapula, we have upwards rotation of the scapula. So we have, I don't know if I said that right, elevation of the clavicle, upward rotation of the scapula. So the scapulothoracic would probably be just doing upward rotation because that's the main thing. But there are times when it mimics the sternoclavicular. I have a few demonstrations of it. So say you're doing protraction motion of your humerus, you're going to have your sternoclavicular is going to protract, and your acromioclavicular is actually going to do that internal rotation. And so we can tell that scapulothoracic is either going to protract or internally rotate, and it's going to do some protraction. So a key question that I would ask is, how do you know if the scapulothoracic will mimic sternoclavicular or acromioclavicular? And that's a much harder thing to do. I honestly don't think they'd ask, like if you were given a multiple choice question, they would only include one of those motions in it, but if they did include both, I'd go with the one that was more pronounced. Even though in protraction, it's literally the term protraction, but that clavicle protraction is much, like if we just had this, there would be nothing going on. But next we have this glenohumeral. That's a joint everyone associates to the shoulder. Just wanted to look into it. Okay, so you can't see the head of the humerus, but it's like this, and then we have this concave, well, that was really bad, this concave scapula. So we're gonna have, since this is the distal and this is the proximal, and we're gonna say it's open chained, well, I don't know, I put an E at the end, open chained, we would have convex on concave, meaning the roll follows the bone and the glide goes in the opposite direction. But just to be clear, I'm always going to probably discuss it in open chain. But if you have closed chain, so say you're doing a push-up, so your hand's touching something, or you're doing a pull-up, those are all closed chain motions. So it's switched to convex on concave. So just keep that in mind, because like they might not ask you about open chain. So, oh, I did miss this point that I wanted to get on. Big thing about this is for the sternoclavicular, acromioclavicular, and scapulothoracic, they're not working on the axes that you would probably think. Just to give an idea, rotation for all three of these joints is sagittal plane, which a lot of people would associate with like flexion extension. So you just need to make sure that you don't get that all messed up. Once you get to the glenohumeral, it kind of goes back to normal. So rotation is on the transverse plane again, and flexion extension is on sagittal, and then abduction, adduction is frontal. So if we're just to do an example, I hope I am not doing the whole rules of convex, concave, and everything, but just an example just to make sure we understand. Convex on concave, which is what we're talking about. So say we're doing abduction, so we're lifting it up, so we're seeing it move superiorly, so the roll is superior, and then the glide's going to be anterior. And so this is a really cool hint, really cool trick. It's been really helpful for me. But it's also, if you're going to be a PT or a medical profession, something else, it's important to understand why this is happening and everything. But for tests, when you are stressed out about memorizing it, this is the fine way, but it doesn't really give you the full understanding of why the glide is occurring and everything. But eventually we'll get there. So all of these joints work together to create that motion of the humerus type of thing. Well, at least what we can see. So that's like scapulohumeral rhythm. So this is the abduction. So 120 degrees is glenohumeral. But in order to get that, we have this 60 degrees of scapulothoracic for the upwards rotation. So it's just this paired thing. You cannot have one without the other. So a good example of this would be, say we're just elevating the clavicle, and we're like, okay, because this is elevation of clavicle, we're gonna have some abduction going on, right? No, you won't. It'll look like a shoulder shrug. So like when you're like saying, I don't know, and you shrug your shoulders, that's what it'll look like. Even though right now we're elevating it and it has a completely different motion, and that's just because of all these pairings. So I think it's important to get these angles down and also understand that there's other motions. So obviously, like the biggest things you can see is this abduction of the glenohumeral, upwards rotation of scapulothoracic and acromioclavicular, and the scapuloclavicular, sternoclavicular elevation. But sternoclavicular is also doing some posterior rotation, some retraction. The acromioclavicular is also doing posterior tilt, external rotation, and those are much harder to visualize, I'd like to think. But if we try to think about it, and I like to try to think it logically through. So the posterior tilt, let's start with that. You're doing abduction. You don't want your shoulder to start going forward. You want a nice open abduction. So you're gonna need that room. So this is gonna need to give that humerus its room. So it's gonna need to tilt back a little. And then that external rotation is also, I would argue, for the room, for the spacing. The idea of the humerus, it just picks up that wind and the scapula kind of goes back a little. And then retraction is just making sure it stays stable. So we don't want it like a forward, you want it in line with your body. You don't want this forward elevation of your humerus, well, abduction. Yeah, I think this one went a little better, but I also feel bad because I think a lot of times you expect to be given every single motion. So we have abduction, like I just gave you abduction, but there's extension, there's internal rotation, there's external rotation, but then there's these in all these different positions. So you just need to do it motion by motion. So just understanding the individual joints will help you piece it together.